So welcome everyone on the second EOS session on when and how to sample lesions. My name is Peter Hendricks from the local faculty. Unfortunately, Professor Kunda mentioned that he was ill this morning, so we had to cancel his lecture. There was also no time for him to pre-record the lecture, but I'm convinced that we will cover the topics that were included in this lecture in the discussion with the experts that I'm having here. I'm co-moderating the session with Koen Raskin. Koen Raskin is gastroenterologist in one of the neighboring hospitals in Ghent, Maria Melares, and he has a long-standing experience in US. And also with Suzanne Ribeiro, digestive oncologist at our department that is also doing US. So first, I'm going to introduce Pierre Eisendrath. He is the head of Department of Gastroenterology at University Hospital Saint-Pierre in Brussels. He has a special interest and expertise in interventional endoscopy and also in ERCP and EOS. The floor is yours, Pierre.
Thank you, Peter, for this nice introduction, and particularly thank you for the invitation for this new Congress. So my task is to discuss with you the place of FNA, FNB when doing in US and when to sample or maybe not to sample. Before to go over, I would like to just give a precision. I won't speak about the things that will increase possibly the diagnostic yield of EOS as elastography or using contrast. I will really stick on a daily practice of the FNA and when to do it and when it is not recommended to do it. And a key to make decision is when you look to the benefit-risk balance of any diagnostic procedure, one of the key points is to know if the technique that we will apply will change the decision or the management decision of the in the treatment or the management of the patient. And this is really the thing I think we have to ask ourselves, is the technique will change something? And if the answer is not, clearly we shouldn't do anything, and this is particularly true for FNA. Whatever the low risk associated with the procedure, and this is the case with this procedure for FNA. In that setting, it would be certainly the goal of the FNA would be to prove pancreatic body, and where really the question is not what it is, but what the cancer, but the question would be what is the diagnosis behind this lesion? Is it really a lesion? Is it acute pancreatic remnant, or is it a neuroendocrine tumor? So can I move to the next slide, please? Yeah, well, so, and the other thing that we have to take in account in this discussion is also the advance in the pancreatic carcinoma treatment. And if in 10 years ago it was really the place for the US to say that the lesion is resectable or not resectable, now we have new treatment coming up with neoadjuvant treatment associating chemotherapy and radiotherapy. And this treatment is certainly to be included in the treatment for, in the management of these patients for borderline resectable lesion, but also for resectable lesion with high-risk features like a high level of CA19-9. So currently, for most of the lesion which looks cancerous, and probably in the future, we will go also for lesions which are resectable. There is a place for FNA and probably more for FNB, but can we discuss that also after? Now they are considered as regional. I personally, if I have a note in that situation, I will do a puncture because I believe it may change the management of this patient. At least it brings a new information on the aggressivity of the tumor if we have a doubt about the aspect of this lymph node for sure. And I would like to finish with this lymphadenopathy of unknown origin. It's a daily or at least a monthly question in my hospital with a patient with lymphadenopathy in the mediastinum or in subphrenic position. We know that USFNA is given diagnostically superior to US alone for these lymph nodes. We know the safety of USFNA is certainly better than mediastinoscopy on surgical sampling. It is also true that for when we have adenopathy everywhere, including subcutaneous adenopathy, then the safety and diagnostic yield is in favor of taking a sample from the subcutaneous region. However, the question is generally when there are no lesions subcutaneously placed, should we go directly to surgical sampling with probably a better diagnostic yield, or should we try first by FNA and FNB? And I think that we have to keep in mind that there are ancillary techniques that may help us to increase the diagnostic yield of FNA. It's not only the technique that the endoscopist is doing, but also what happens after.
Thank you very much, Pierre, for this excellent presentation. And I think that you raised several points for discussion. I'm looking first to my colleague, whether she received maybe some questions from the audience or...
I don't have questions yet from the audience, but I would like to ask a question, if I might. For the GISTs, for example, if you see a subepithelial lesion, that is quite characteristic for a GIST in the stomach. It is more than 2 centimeters. Do you always perform, or which measures do you take in order to avoid the seeding? Because it is a deep lesion, it's mostly in the 4th layer. What are your ideas about it in this case? Okay. Do you always puncture?
So, again, I keep my first rules before to do the FNA. It's asking myself if I would change something for the management of the patient. So if there is a clear indication for surgery and the aspect of the GIST is clear, I wouldn't do any puncture. I will send the patient for surgery. Okay. However, in the daily life, there is some situation where we don't know exactly what will happen to the patient, depending of the comorbidities of patient, the age of the patient, the localization also of the GIST. GIST from the great curvature are more easy to send for surgery than the one which is on the small curvature, where the surgery will be more, probably more extended. Yeah. So these are points I have to also keep in mind when I discussing to do or not to do the FNA or the FNB. If I am doing it, if I have to do it, whatever the reason, I will try not to go through the GIST, and I will keep my needle into the GIST from the gastric wall and not going into the peritoneum. This is the way I try to reduce the risk of seeding.
Thank you. Thank you.
Okay. Koen, do you have questions?
Pierre, isn't it time to switch to FNB needles? Because you get more information for the oncologist. You get course, and they can. That gives more information for the treatment.
Yeah, that's
and especially in all types of masses, pancreatic masses, nodules, even GIST. If you do the puncture.
I perfectly agree with you. I really think that in the future we will only have what we call FNB lesion. Yeah. Just to remind to the audience that the definition of FNB lesion is a bit arbitrary. It's just the fact that increase the number of core in the specimen. We were able to have histologic in certain circumstances with FNA needle, but just the design of new needle with the increase of the percentage of histologic or core in the sample make that we call them FNB lesion, FNB needle. That's one thing. But I really think that in the future we will only have what we call FNB needle. Currently, there is still a debate of cost.